So this is chapter 13 in the book of Eli, Trauma Patient Assessment, or TPA. So the question has to be asked and answered. What is a patient assessment? You, as EMTs, are going to study and be proficient in two types of patient assessment. This is the first one, and I really believe this is the key to both of them. And the better you are at trauma patient assessment, the easier things will be for you all when we do medical patient assessment later on in the course. So really learn this stuff. The concept behind it is very simple. It is a very large state, as you know, and you could be working with anybody from absolutely anywhere in the state of New York. So you could have a guy that went to school in Buffalo. You could have a guy that went to school in Binghamton, Syracuse, Albany, or here downstate, anywhere. And you would all be working together. So even though obviously the scope of practice is going to be the same, you have to have a methodology, a way to determine what is going on with your patient. And so trauma patient assessment was developed, and this applies to anybody who a trauma has befallen them. So you have here with the little mouse, and he's whacking the hammer over the cat's head. What is a trauma? What's pshat, if you like? What is the definition of a trauma? So a trauma is where a human body, is acted upon by an outside force. So over here, we have this huge mallet or hammer, and it is a force that is being acted upon onto the cat's body. This is a trauma. And anything that you can think of, whether it's gunshot wounds, stabbing, car accidents, falls, etc., all these are considered traumas. And a trauma has to be dealt with in a certain way. The opposite of a trauma, don't want to get into it tonight, is anything, we call it medical, and it's anything that, let's say, makes a person sick. Somebody is ill, somebody is sick, somebody has a pain on the inside. That's all medical. And we'll get to that later on. Tonight, we're dealing with trauma. Now, trauma varies from, let's say, banging your toe into the leg of the couch. That's a trauma, okay? And so is a 20-foot fall from a ladder is also a trauma. Now, hopefully you understand that there's a huge difference between these two traumas. You could get called for either. There's no law book of when a patient can call 911 or when not to. Someone got hurt, whether it was a splinter from the wood, whether they stapled a staple into the finger, or whether they made a small cut in the hand chopping an onion, a carrot, etc., or a motorcycle accident where the guy is in life or death critical condition. So it really goes from the very simple basic all the way to very complex and life-threatening. I will just emphasize now, before we even start, that all the trauma we talk about in class, whether in the skill or whether in the lecture, is all life-threatening, is all severe trauma, serious traumas. So don't think a lot of this will not apply to somebody that bumped their toe on the leg of the couch, for example. It's not going to be the same situation. Here we're talking about serious traumas, gunshot wounds, stabbings, motor vehicle accidents, pedestrian struck, falls of great heights, etc., etc. So that's what we're dealing with tonight, and we're going to learn how to take care of it. The trauma patient assessment, which I call TPA, all right, get used to that, TPA, is split up into many parts. What I will do is go through it tonight and explain the purpose and the function of each of these parts. We will practice these many, many times during skill nights. But first, you need to get the understanding of what you're doing. We start everything with scene size up, BSI, if you want to call it PPE. We've discussed this already. So your safety, remember, is number one. Okay, if the shooter is still there, you know, there's a famous story in 911 where there's a guy with a gun and EMS comes over and starts treating the patient. And the guy with the gun says, is he okay? Is he going to make it? And the EMTs, whatever it was, says, yeah, I think we're going to move now quickly to the hospital. I think we'll make it. So the guy with the gun shoots the guy 3 more times, says, no, he won't. So you don't understand what's going on at these scenes. They are very hectic. There is a lot of bystanders, spectators, and it can really get out of control. Your job is scene safety. Is this safe for me? Is this scene safe for me and my partner? Okay, and scene safety falls into many different categories. Could be there are wild animals such as dogs. It could be there's people with weapons, and it could be that there's a car that's on fire. All these would render the scene unsafe. Just giving you a few examples. We're going to talk about this acronym MOI. MOI. And these are things that you've got to know, and it's got to become part of your language. MOI, mechanism of injury. It's very simple. What happened? What happened? Okay? This guy hit that guy. This guy punched that guy. This guy fell from a window. This guy got shot. MOI. How did it happen? And usually not in medical terms. Usually it's just in regular English. Okay, how did it happen? What happened? Additional resources. Do we need extra help? In the state exam, you're going to have a serious patient. So for additional resources and ALS. Ask for medics. Whether you need them or not, understand that in real life, medics can always be canceled. And really at any time. And it's really the job of the EMTs. So I'm just giving you, for the state exam, additional resources. We're going to go with it. Impression of the patient. General impression of the patient. You'll see why certain letters are in blue. We'll get to that later. Okay, does the patient look male or female? Does the patient look like they're going to die? Does the patient look like they're in their teenage years? Does the patient look like they're 60, 70 years? Maybe they look 80 years. It's not an exact science. General impression is, what do you see? What do you see when you walk up on scene? Life check and life threats. It's going to be the L. Let me give you the easiest one. Life threat would be a spurting artery. Okay? They've been hit, they're bleeding, there's an artery spurting, and that must be dealt with immediately. That must be dealt with immediately. You cannot wait until the proper place for dealing with bleeding. If somebody, you come on scene, they have a spurting artery, deal with it right here. Life check means if they look unresponsive to you, do a carotid pulse check. See if they're alive. Okay? It won't be obvious always. So that's where you get life check, life threats. Stabilize the spine, PRN. So you see here in the bottom picture, this is how you do a manual stabilization. Okay, no collar, no backboard, just get a bystander, a partner, a firefighter to hold manual stabilization. Why? Because we spoke about this already. We want spinal motion restriction. We don't know what's the situation yet with the head, with the neck. So let's do some spinal motion restriction. And we just do it like that with our hands. Chief complaint is a question. It's always the same question. Why did you call 911? Why did you call an ambulance? Now, assuming they are unresponsive, they can't answer you. So the answer is chief complaint, unresponsive at this time. Okay, it's that simple. H, the last part of this scene size up, how many patients? All right, remember, if you have a collision of two minivans and there are people strewn all over the road, okay, there could be 14 patients, theoretically, right? Never assume that it's only that one person that you noticed when you walked up to the scene. So how many patients? This is going to be a question that you need to investigate and get help with. So this is the scene size up. Okay, now we're going to do something called the primary assessment. All right, what's a primary assessment? Primary is first, is initial, it's at the beginning. And this is something they can ask, and they might ask on exams, what is the purpose? Why would you do a primary assessment? So here you have it. It's intended to locate and treat life-threatening injuries. Life-threatening injuries. That's now what we're going to be looking for. And we'll show you how we break it down. So this next part is all primary assessment. All right, AFPU. Remember AFPU? We've spoken about it numerous times. You should know how to determine if somebody is alert, verbal, pain, or unresponsive. We have covered this. Remember, to be alert, they answer 3 questions correctly. And the questions fall into these categories: person, place, and time. If they get one wrong, two wrong, or they don't answer any of them, then we see if they're verbal. Do they respond in any way to your verbal stimuli? Do they respond to you when you talk to them? Yes or no? If it's no, we go to pain, and now we inflict pain. We'll show you how to do these things on skill nights. They respond to pain, they don't respond to pain, we need to know. Unresponsive means they did not respond to any of these. Make sure you understand this, make sure you know how to do this. All right, airway, breathing, and circulation. I'm going to do this at the end with the chart that I gave you last night. I'm going to show you how we do this. Once we've completed our airway, breathing, and circulation steps, we need to make a transport decision. And pretty much it's always going to be a load and go for the critical and the potentially unstable patients. You do not need to learn this list. Just look at it at some point and understand that anybody that fits into any of these boxes will be a load and go, a critical patient. This is more criteria that would put somebody in a load and go. If you just look, systolic less than 90, so we know what that means. That means they're possibly in decompensated shock. Okay, GCS less than or equal to 13. So if they lost 2 points on their GCS from 15 to 13, makes them critical, and all these other things. You don't need to learn these. Fall or more of 20 feet. This is a good thing to remember. All right, so anybody that fell 20 feet or more, okay, is critical. All right. In general, we talk about patients on anticoagulant medications. So you'll see soon that we need to know more information about the patient, but just a general rule.
What is that? Anticoagulant?
I'm going to explain. Just a general rule that any patient who takes blood thinners, which is the anticoagulant medication, blood thinners, and there are many, many reasons why we might put patients on an anticoagulant. And if they fall, they bump their head, they do any sort of thing like that, they go in. They're critical patients because you have no idea what's going on the inside and how much blood they may lose. The opposite of load and go is stay and play. Now, you won't get one of these in the state exam, but these are minor injuries, things that you can treat first, transport later. Anything that's not critical, unstable, or potentially unstable will be a stable patient, and we call these stay and play. We will not be dealing with this. There's something called a rapid scan, and it's always very complicated because in real life, we do a rapid scan at this point. The state does not require it at this point. So I'm always torn with whether to teach it, not to teach it, make you do it, don't make you do it. It's an extra bunch of steps. It's what we do in real life. However, we're not really doing it on the state exam. So we'll circle back to it. All right, rapid scan is also known as a head to toe. And I list here some of the things that you're going to look for during this rapid scan. Okay. All right, a new acronym, and this you're going to learn. You got to know this tonight. DCAP BTLS. That's how you pronounce it. DCAP BTLS. These are all the boo-boos that a patient can pretty much get. If you look, D, deformities, that's where one arm or leg doesn't look like their other one. Contusions, hopefully we remember those are bruises. Abrasions, like the kid at the bottom, it's a scrape. Punctures would be that needle going through the skin. Burns, obvious. Tenderness means when you touch it, it hurts them. Lacerations are cuts. And swelling is swelling. So this is an acronym called DCAP BTLS. You have to learn it. You will be tested on it. I've seen even the state tests, what is the P of DCAP BTLS, for example. It could be any of them. So learn this. These are all boo-boos. All right. I've taught you sample history in one of the earlier classes. I'm going to run through it again, but we're not going to spend a lot of time on it now. And the reason being is that all these patients are going to be unresponsive. So it's going to be very difficult to ask them 6 questions if they're unresponsive. The way you do it on the exam at the end is you say, is there anybody with the patient? You ask the examiner, the instructor, is there anybody with the patient who can answer sample history? And there will not be, and that's it. You get 1 point on the test just for mentioning sample history. So again, just to run through it quickly, we've done this before, S's signs and symptoms. Again, when we do the medical patient, we're going to actually ask these and get answers, okay? A is allergies to whatever, M is what meds do they take, and here's where we find out about the anticoagulants, right? This is where we'd find out. P, past medical history. This will be linked to this because hopefully the medications will match the past medical history. L is the last meal or last oral intake or whatever. E, events leading up to what's going on in their life. I like to use it for socially, emotionally, that sort of stuff.
And what are you doing if you find a patient on the floor without anybody around them?
Right, so there will be no sample history. You can't get one.
Okay.
Okay.
I mean, always up triage, right?
I'm not sure how that comes into it. Either we can get a sample history or we can't. The state expects you to get one. Set, unless you can, unless they're unresponsive. Vital signs, we've spoken about, we've done it, we've learned it, we practiced blood pressure, pulse, respiration, skin, pupils, and cap refill. This we'll talk about when we do pediatrics. It's not used on everybody, so don't worry about it right now. But the basic vital signs are what we need to know. Okay, we've spoken about this before, but now I want to really get into the differences. Normal pupils, right? And then again, this is not with a light, no pen light, no mag light, no phone light, nothing. Open their eyes and tell me what you see. Okay, so normal pupils, great. Constricted. All right, anyone remember what they did to get these pupils? They did. Anybody? Narcotics,
Drugs,
opiates. You can't say drugs anymore. Okay, we've got to get it. We've got to up the game so we know exactly what we're talking about. Opiates, all right, will look like this: heroin, oxycodone, oxycontin, dilaudid, fentanyl, morphine. All right, these are a few of my favorite things. Okay, so that's what we're looking at. Dilated. Look at the size of those pupils. So yes, they may have come from the optometrist, and then they got hit by a car, or they may have been doing things like crack cocaine and upper stimulants. So that would be looking like this. The one we're doing now, I put all four in because I don't want to hear that, oh, we didn't know or whatever. Now you know all the different types. Unequal pupils. And the mannequin in Bay Parkway, I don't know if anyone saw it, but there's a mannequin in Bay Parkway with unequal pupils. Very, very cool. So unequal just means they're not the same. Right? They're not shining a light. They're just looking at the pupils. Now, typically, if you shine a light into normal pupils, what will the reaction be? It will be they will constrict. But when you take the light away, they will go back to normal pupils. So we're talking about without light, without anything. Okay, so it's a quick review. Well, we did the primary assessment. Now we got to talk about the secondary assessment. Obviously, primary comes first, secondary comes second. Wow, amazing. Now, we're going to do an in-depth examination of the patient. What are we looking for now? Non-life-threatening injuries. So let's just get this very clear. Primary assessment is to locate and treat. Notice, locate and treat. Okay, life threats. You don't wait for later. You treat right away if you see something. But all the other stuff, like this guy got a sore toe, we do later. And we can do it en route. Okay, and that would all fall into the secondary. All right, I'm not going to read this to you. Hopefully you all have the book. But in the secondary, we're going to look, starting with the head, always head to toe. We're not actually going to bandage the brain, but we're going to look for all the stuff that we've spoken about. We spoke about head, neck injuries. We look for drainage of fluid from any of the orifices of the head. Go to the neck. We know about JVD. Maybe we need to apply a collar. Maybe we don't. We've discussed that. All right. We look for tenderness and all the other good stuff. Chest. We look.
Can I just disturb you for a second?
Sure.
Okay. Can you? How does this chain work? We're starting with.
So we're gonna, check the chest. We're gonna look for different types of motion, equal, unequal chest rise, lung sounds. All right. We're just going down and down. We go to the abdomen. We'll show you how to check the 4 quadrants. We look for rebound tenderness, point tenderness. I'm sure I've spoken about those previously. Pelvis for stability, and then the 4 extremities, right? Lower extremities, upper extremities, posterior, which is the back, the buttocks, all right? Everything has to be checked. All right, the last thing you want to do is called an ongoing assessment. And this is the last acronym for this session. I'm going to show you some more that we skipped, but this is 5. So when is this done? Every 5 minutes for the unstable patient. All right, so it's step 5. acronym is 5, and it's done every 5 minutes because your patient will be unstable. You will do a focused exam. What does that mean? That means any way you found the problem on the patient, you need to keep an eye on it. You need to recheck it every 5 minutes. Initial exam is the primary assessment, which is going to be the ABCs. You'll repeat everything I show you every 5 minutes. V is vital signs, which is broken down, will be blood pressure, heart rate, respiratory rate, en route every 5 minutes. And E, everything you did for the patient. So if you gave the patient oxygen, make sure the oxygen is running. If you bandaged something, make sure it's not bleeding through. So everything you did for the patient needs to be checked. CFIVE 5. Okay. Trauma centers, this is not something you'll be tested on, but if you're gonna be in the New York City area, we have 3 in Brooklyn. Okay, depending on where you are. Few in Queens, Staten Island has just the 1, and Manhattan has a whole bunch, and the Bronx. So every neighborhood, every borough in the city has trauma centers. So just, again, you don't need to learn these. Okay, so how do we put it all together? So I made this chart. I made it in about 2005, and then the state decided to change things around. So I redid it. This is the latest one. It's the same since 2018. And this is the way that you will do it. I highly recommend that you have a chart like this with you at all skill sessions now. And yeah, this is going to be putting it all together. So hopefully I'll answer those questions. All right, some rules. Rules are we need to complete a column before moving to the next column. All right, I made this literally as simple as I can and cover all the bases. So you want to stick in a column. Can you mix things up within the column? So the answer is yes and no. All right, BSI and scene safety needs to be done first, otherwise you'll fail the test. Everything else in that column can be done honestly in any order you want, but I would highly recommend that you remember Males CH. Males CH is an acronym, and that will give you everything that you need to do. Hold on, let me explain. Everything that you need to do for that column, right? So again, the last column is numbered. The fact that it's numbered, you cannot change the order. It must be in that order. All right. The other columns, do it however you want. If you remember it a better way, do it. I don't care. If you have watched something online, YouTube, doing it, as long as it's appropriate for New York State and they're not missing anything, I don't care. But I have hundreds and hundreds, thousands even, students who do it like this, and they do just fine. So I highly recommend you use this method. I'm going to go through it now so you understand, and then we're going to do it on skill nights, and we're going to do it over and over and over. You need to do it without the paper. You can start off with the paper, but you got to get rid of the paper, and you got to be able to just do it. Okay, so here we go. Column, remember, we're going to finish a column before moving to the next column. BSI scene safety must be first. Now we have males, CH. What is males? MOI, mechanism of injury. Ask the examiner, or they'll tell you you're responding to a patient who fell out of a fifth-story window. Okay, so repeat it back to them. My MOI is that the patient fell out of a fifth-story window. You see, you got the information. Additional resources, like I told you, always call for ALS. So yes, call for ALS. I told you impression. What do the patient look like? They look like they're dead. They look like they have a chance of life. Maybe they're talking. Maybe they're not. I don't know. Male, female, approximate age. Just by the way you look at them. Do they look like they're in the 60s or the 80s? Or do they look like they're, high school? Impression. Life check, life threats. Okay, so I spoke to you about that. If you see a major bleed, whether it be an arterial bleed, easiest to see, a venous bleed, also, if you see it without investigating, that is a life threat. Life check, if they're unresponsive, you need to do a carotid pulse check. If they're talking to you, then life check, yeah, they're alive, done. Spinal will be PRN per required need, as you need it, or as you feel is necessary. C, chief complaint. Always get used to asking your patient, why did you call 911? Why did you call EMS? And obviously, if they don't answer you, they don't answer you. That's fine too. How many patients are at this scene? You will have to ask somebody else. There may be firefighters, there may be cops, there may be bystanders. In the exam, you'll ask the examiner, how many patients do I have? LOC stands for level of consciousness. LOC, level of consciousness. And that we have the 4 types: alert, verbal, pain, and unresponsive. Now, a lot of people are going to do, why'd you call 911? Oh, they didn't answer me. Okay, so they're unresponsive. And you just messed yourself over. Okay? So I've told you many, many times now. To be unresponsive, you got to go through all the above. You got to talk to them, see if they respond properly. You got to talk to them, see if they're verbal, see if they punch you, kick you, do something, inflict pain. All you need is a moan or a groan. Okay? And no to all of those, yeah, then you can say your patient's unresponsive. So don't jump. All right, that is the scene size up column. Does anyone have a specific question on that column? Okay, I will address things obviously as we go along. Airway. So now we're going to do airway. We have this acronym COMA, COMA, COMA. All right, and that stands for the 3 things you got to do to deal with an airway. You have to clear an airway, open the airway, maintain the airway, and A for airway, so that we have a word, COMA. 3 things. Each one of these 3 things can be done in 2 ways by an EMT. So now I'm making you think. All right, let's start with clear. There are 2 ways to clear an airway. 2 ways that we've discussed, that we've shown you, we've spoken about. The first one was the finger sweep. Okay. What gets swept out of an airway? What?
An object.
Okay, solids, right? Solids or large food stuff okay, would get finger sweat. Now, we can also suction. What gets suctioned?
Fluid.
Fluids, liquids, right? Very good. So we have two methods, all right? And we want to clear the airway. I think we need to ask the examiner what's in the airway and respond appropriately, okay? O is open. We have two methods of opening the airway. We have the atraumatic, which is the head tilt chin lift for non-trauma, atraumatic. And then we have, for head trauma, we have the modified jaw thrust. You have to make a decision. Which one are you going to use? I don't want to hear people saying things like, well, I could either use or I could do the. If you do that, then you're not living the story. You're not understanding what the examiner set this scenario. So let's say the patient was thrown from a 5th-story window. What do you think? Head trauma? Yes or no?
Yes.
Definite possibility, I would say, right? And in which case, how are we going to open the airway?
Jaw thrust.
Modified jaw thrust, right? So you see, you have to make these decisions and maintain. Okay, we have two methods. We have OPA, we have OPA, and we have NPA. Now we know that OPA is preferred. The problem is when we put it in, we have to look to see what happens to the patient. They might have a gag reflex to the OPA. So if they do, take it out. Take it out. That's it, done. Now, you cannot use NPA in a possible head trauma. It's off the possibility is not there. So in a major trauma, it's OPA. They don't accept it, take it out. COMA, clear, open, maintain the airway. Good. Easy column, right?
What's the M? I'm sorry. What was the M?
Maintain, OPA or NPA.
And the A? Just airway.
Just airway, just to make it a word, coma. Breathing column. We're going to use this town in Texas called El Paso. All right, and we got to remember this. E, expose the patient's chest. Expose, right? L, look. What are we looking for? Well, we're looking for gunshot wound, sucking chest wound, paradoxical chest wall movement, equal chest wall movement. We're looking for lacerations. We're looking for, I mean, absolutely anything. And you got to say a whole bunch of things that you're looking for. So whatever comes to mind could be something you'd be looking for here, but try to keep it specific to chest. All right. We're also looking at the neck. So we've got JVD. We could look for the trachea, tracheal deviation. These are all good things to talk about. P is palpate. We're still talking about the chest. I cannot explain how to do that in a lecture, but you will be shown on a skill night how to palpate the chest correctly. We're looking for broken bones, flail segments, stuff like that. A, auscultate. Auscultate. What does the word mean? It means to listen. All right. Again, auscultate means to listen with a stethoscope. So we're going to learn where to put the stethoscope, and we're going to listen in usually 4 places to the chest. Seal, stabilize. So what gets sealed? Well, a sucking chest wound gets sealed. We know this. We've done this. So a sucking chest wound gets sealed. Stabilized will be if there is an impaled object and it's still there. So let's think about maybe a knife, dagger, something got impaled in the patient. We don't want it to move around. We will stabilize it. At that point, I put a star. Star means think. Think. We're going to give the patient oxygen. Okay? So we have to choose the mask and give the right amount of oxygen. One way will be to look at respiratory rate. So if the respiratory, here's a general rule. If the respiratory rate is less than 8, you're going to ventilate. Okay, it's like a general rule, which means if they're breathing less than 8 times in a minute, you're probably going to want to ventilate with a BVM. If they're breathing more than 8, we're towards normal limits, and then even higher than that, you'll be fine with a non-rebreather. Remember, you got to tell the examiner with the non-rebreather or with the BVM, it's going to be at 15 liters per minute, because that's the way we do it. All right, that is the breathing column. Again, this is very hands-on, so we'll be doing this skill nights. Circulation, you have 3 letters, PBS, peanut butter sandwiches. There was another way somebody told me, I don't remember it, but PBS, peanut butter sandwiches, or pulse, leading, and skin, PBS. So pulses, radial pulses, both. You want to check both radial pulses. You know there's a carotid pulse because you checked it a few columns earlier in life threats, life check, right? So now we want to know, are there radial pulses? Patient has no radial pulses. What would you do?
CPR.
CPR.
Absolutely not.
Look between the radial pulse and the heart.
Someone has no radial pulses. What would you do?
Oh, radial.
Check the others.
Straight. Check out the obstruction, if there is an obstruction.
There's no obstruction. You're checking both arms and there's no radial pulse.
Check the pulse by his neck. What's it called?
Okay, I think I didn't hear you clearly, but I think you said check the carotid pulse again, right?
I don't remember the name, but yes, that's what I said.
Good. So you want to check the carotid pulse. All right. You do not, it's a trick question. I always ask that. You do not start CPR. All right. Somebody with no radial pulses is very likely to be in shock and maybe even in decompensated shock. Maybe. But certainly they're not dead. The only way we determine lifelessness or dead is the absence of a carotid pulse. So check both radial pulses simultaneously. B, bleeding. So now you're cutting off the pains, you're cutting off whatever else you need to see, and now we're looking for any active bleeding. It would have to be life-threatening, but certainly if there is, you would treat bleeding. Skin, there's 3 things. We've spoken about this. We look for color, temperature, and condition. You will ask the examiner what is the status of the color, temperature, condition of the skin, and they'll tell you, right? After that, we'll skip the rapid scan. We'll go to our transport decision. It's got its own column. And I wrote there what you got to say. Load and go. Don't start thinking and humming and harring and no, load and go. That's it. My decision, load and go. It got its own column. Last column. All right, 5 steps. Step number 1 is a history, sample history. So I told you before, if there's nobody around and the patient is unresponsive, you can't get one. Boom. It's only worth 1 point here. Number 2 is called the secondary assessment. This is going to be a complete head to toe. And I need you to read those paragraphs that I wrote, and we will show you how to do it in a skill class, head to toe. 3 is your first set of vital signs. All right. And again, the ones I want more than anything else is blood pressure, heart rate, respiratory rate. Okay. Actual numbers now. Number 4 will be interventions and treatment. So anything that was minor that you did not treat because it was not part of the primary, which is the airway, breathing, circulation, but it was found in the secondary, then we may be able to treat. Well, that could be a broken bone, that could be some other injury, dislocation. It can all be done here in number 4. Number 5,
Yeah.
number 5 is the ongoing assessment. And again, I wrote it again here, and it's on the other page. It's done every 5 minutes. Q in medicine means every. So every 5 minutes. And what are the 5? What is it? Well, the acronym is 5. Step 5, every 5 minutes, 5, F-I-V-E. Focus, initial vitals, and everything you did for the patient. All this is being done en route. Okay, all this is being done.